Yes. Yes, yes. I am
म्हणजे सर
the
मी
host
मी
now.
मी माझं सगळं म्हणजे सर मी ओपन करून ठेवते, राहू देत, काय प्रॉब्लेम आला तर. ओके,
हो, ठीक आहे,
मी
ठीक.
1-1.5 तासांनी येते परत.
हो, चालेल, चालेल.
हा, नाही चल, 1-1.5 तासांनी येते.
Yes.
थँक्यू
Uh,
एव्हरीवन.
so Care Hospital, you can be on unmute because, since there is only one window today, so you can be on unmute so that whenever we are interacting, you need not to mute, unmute again and again. So, very good afternoon and thank you for coming on time, before time actually. So, first, just let me know that my voice is clear in the hall to everyone, or you need to adjust your speaker or something like that. If you want to do that, then you can do that quickly. Then we can start on content. So, Care Hospital, unless you unmute and tell me what is going on, I cannot, proceed ahead.
Yes, sir.
Yes. So, am I audible to everyone?
Yes, sir.
Okay, great. Um, you are like whole team is sitting. So have you everyone attended the clinical sessions?
We have attended the clinical section, sir, but it is Hindi, no? It is difficult to understand. That's what we are requested to
No
Hindi.
problem, no problem. But then, Hindi session, whom all attended from this these participant?
Answer. We all are participating in this thing, sir.
Okay. So majority of them have already attended it, whether irrespective of understanding.
Yes, sir.
Yeah, okay. So, no problem. We'll just start with the English one. So
Okay.
today we are going to have review of revision of every every standard. So in one go we will be taking revision of first to 16 standard. Okay.
Okay, sir.
Uh, Before that, if you have any queries, or maybe if you want to ask queries after my lecture, you can do that. If there are any specific queries regarding preparation and everything, you can ask now also or maybe later also. Okay. So be ready with your queries, questions, whatever it is, because your assessment will be mostly in this month itself. So you need to be prepared in every aspect. Okay, so I hope my English is understandable to everyone.
Yes, sir. Yes, sir. It's fine.
Yes, okay. So uh, uh, today the agenda of this session is we are going to, uh, not going to have the presentations. We are directly going to have a one-on-one interaction, and also the sequence of standards will be like from first to 16. Sometimes, it may shuffle in between, but then it will be from the perspective of assessment. So, like I will also tell you that how questions will be asked and what you should be answering. There is no ideal way of answering, but then yeah, you need to know what can be asked and in what way you give the answer. Okay. So we will I'll just start with the first standard. Okay. Before that, I'll just let you know some etiquette, some top skills to use, some preparation, pre work to do before assessment, and you know how to look aesthetic, how to look elegant, and how to look confident. That suggestions I will give to you. So basically, the first thing you need to do at the time of assessment is to make sure that you are sitting in a room where is a least disturbance is there. You should be sitting in a room where network is strong and also there will be no disturbance. So uh, the suggestion is you sit in the room and lock that room for 2 hours or 1 hour, whatever times it takes for assessment, so that nobody will come. Like most of the time sister sits and no doctors are allowed to sit in the assessment. So sisters had that duty of IV saline lagana hai, yeah, any emergency came, then like that. So people are calling sisters, yeah, you come to help us, or you come that you are required there for patient or something like that. So that should not happen. You should communicate everyone that you will be busy for next 2 hours or maybe 1 hour, whatever the timing you have given for the assessment. Majority of the time it happens under 1 hour only, because it is just question and answer. It is not kind of they are delivering something, delivering some lectures or something like that. So it is like that. So you have to be like, in a place where there is a least disturbance and strong network is there. If you are sitting with your phone, it's okay to sit with the phone, but then you have to have the Google account, because the assessment happens on Gmeet, Google Meet. Right now we are on Zoom platform, but it doesn't happen on Zoom platform. It happens on Gmail. So Gmeet. So you should have the Gmail account.
Sir, 1 second, sir.
Yeah.
This meeting recording also we need, sir, after
Yeah,
say.
yeah. I'm recording it and I'll upload it and I'll share it. Definitely I'll share it.
Okay.
In
And we
start
can
only, I
access
told
the
Jyotsna ma'am that make me the
assessment.
host so that I can record it.
Okay. Is it possible to do 2 times assessment, sir? Because all of them are in at a time. Maybe it is not possible.
Sorry, I did not get you. What you said?
Is it possible to do the assessment 2 times, like 2 batches?
No, it is that kind of provision is not there. It
Okay.
is you can do the one thing. If you wish to have two groups, you can log in from two devices.
Okay.
Yeah. So it happens for hospital. It doesn't happen for staff.
Okay.
So minimum staff required is 4, and maximum you can have as much as you can. Okay. So you can have the two devices in people sitting in 2 rooms, not in a one room, single room. If you are adding two devices, then it echoes a lot. So you should be sitting in the different rooms if two different groups are there. So at the time of assessment, these things you make sure. Then when assessment start, before starting the assessment, you need to be there before 15 minutes. Like if their assessment is scheduled at 2 p.m., you should be there by 1:45. You should log in from the device. If you are logging from the mobile, it's fine, but then make sure that you have the Gmail account. And before that also, you try login from some other Gmail, other Google Meet link. You create a link and you just try logging in from that. Okay. And one more thing, you should make sure that whenever assessment starts, you should not be, you should not be moving from the one place to another place like that. So you fix the angle, and if 5 people, 10 people are sitting, everyone should be visible. You set the angle like that, and no one should move after assessment starts. So like sometimes what happens ki, sometimes some emergency comes, or maybe sometimes our personal thing, like you have to go to washroom or something like that. So yeah, if there is any urgency, you can obviously you can get up and go. But the thing is, at that time you should take permission of assessor that, sir, I have this thing, either personal or maybe work of your hospital. You should be taking permission also while joining. I mean, after completing your task, you are coming back and you want to join, you also take permission at that time that, sir, my work is done. I want to again rejoin. So, or ma'am, whatever, whomsoever the assessor is, he or she. So you should, take permission. Whenever assessor comes in, greet him. Hello, sir. If it is in morning, say good morning, or maybe so that you will develop a rapport with them, and you will not you will feel comfortable to talk with him when she or he asks the questions, and it is very good to have communication and build a rapport before before it is actually the technical thing starts. So greet them, then have smile on your face, be confident, don't slouch. So that those are the soft skills you use. Other things is like if you have the uniform, uh, of your hospital or ID card. So at that day, wear that thing, uniform, and ID card also. If possible, if there is a provision of apron to you, you can wear apron too. If there is no uniform, you can wear apron too. Okay. So apron would be also fine. And ID card is, if ID card is not there, it's fine. No ID card. If no ID card, you can't wear anything. So it's fine. But if it is there, then wear it. Okay. Um, so these are the just general instruction you should be following in the assessment. And um, if you are joining from laptop, make sure that battery is enough, or maybe you can connect to the plug where you can sit where the electricity point is there, and then you can plug in the charger and have that charging sufficient charging at the time of assessment. So I suggest if you have laptop, you connect from laptop only because laptop has that wide angle. Mobile is like a small small screen is there, and it is like very difficult to adjust many peoples in that. And from laptop, it is like visible even if you sit back like thoda distance pe, then it is visible to everyone. So you can sit at distance and it is very much visible. Like right now you are sitting in the hall. It is also possible that you can sit here and then have the assessment. So you decide wherever you want to sit, but then make sure that network is enough, and then there is no disturbance or noise in the hall or maybe the room. Okay, so we will just jump to the content, uh, Manyata content. And before that, I would like to hear from you that what kind of preparation till now you have done for the Manyata assessment. I just want to know that.
We all kept ready labor room and sets and all, everything is ready, sir.
Okay. So
Medication,
in labor room, when you say labor room, what all there?
normal delivery sets, post PPH set, baby set, kit,
Okay.
emergency drugs,
Okay.
and
Okay.
eclampsia drugs, everything we kept ready.
Okay, okay. So all that like the PPH kit, eclampsia kit, and the newborn resuscitation kit is in the plastic box, right?
Yes, sir. Yes.
Okay. Like Josna ma'am has already shown you.
Yes, sir.
Okay, and is there newborn corner ready?
Yes, sir.
Okay. Okay, so you have everything in the place. Also, the posters.
Posters also,
Some poster I need to share it because I haven't shared it to
Yes.
avoid confusion.
Once you share, we will keep it ready, sir.
Yeah, so print it out, and then at appropriate places you need to stick it. So like if there is normal delivery ka poster, then you will have to stick it at labor room. If it is of AMTSL, then it is also goes to labor room. If it is of breastfeeding, then you need to stick it to maybe ward. If it is for OGTT, it needs to be in OPD. If it is for hand washing, then it needs to be at hand washing station. Likewise, you just paste it wherever it is appropriate. So I'll share it, and you just take print out and stick it wherever you feel like. Then another thing is, are you ready with the biomedical waste boxes, the color coded boxes,
Yes,
color
sir.
coded bins? Okay. Okay. And for cleaning, what do you use? Do you use 0.5
I use basil acid, sir.
hypochlorite solution or?
Basil acid and hypochlorite solution, both you
Okay,
need.
ठीक है. So you have hypochlorite solution, so no need to make that bleaching powder solution. That's fine. Um, okay. So I think you are prepared, and are you started plotting partograph as well?
Yes, yes, sir.
Okay, okay, okay. So that's great.
New one only we are following up.
Okay, okay, okay. So everyone is confident in plotting partograph after training?
Yes, sir.
Okay, okay. If there is anything in partograph, you can reach out
Anyway,
to
once
me.
you today also in this session, once you explain, sir, but other people also have.
Yeah, I'm going to explain everything where, I mean, irrespective of you know it or not. But yeah, if you have any further doubts also, you can ask me. So I will jump to the content then. The first standard is about antenatal care. So when we say antenatal care, so antenatal care is not kind of care we give to the patient. It is the normal thing. Our lady coming to your clinic for this kind of care is not a patient. It's a normal process that happens. Reproduction process happens in the body, and it is not kind of disease or anything, any ailment. It is a normal process. You just have to facilitate it. Okay. So facilitation means what? That you just need to screen the patient that in this normal process, everything in the body is at normal level. Okay, because because this is something which is happening differently from the normal routine life. That's why you are just monitoring lady that everything is normal. Every I mean every body fluid level, or maybe some component of blood, or some whatever physiologically in the body is perfect. Okay. So you just need to screen patient, and this kind of care is not care what we say in the hospital for the for the disease care. It is not kind of disease care. It is just facilitating the process of the body which is happening naturally. So in this thing, in antenatal care, assessor, I will first tell you that how question will come to you in assessment. So in assessment, question will be like, there is one lady who has missed her period since 2 months, and she is coming to your clinic, and two nurses are sitting at reception. No doctor is available, and they are asking nurses that my period is missed since 2 months, and I am worried, and what should I do next? So this kind of question she will ask, and then assessor will ask you, in this case, what will you do? Okay. So the ideal answer should be, you will be doing first UPT for her, urine pregnancy test. Okay. So first you will confirm the urine pregnancy test. If it is negative, then you will if you feel that this patient is not has non-pregnant uterus but has some problem with hormones, you will ask her to visit doctor whenever doctor will be available. Okay. But if UPT comes positive, then what will you do next? You will send these patient to have confirmation by USG, by ultrasonography. Okay. So
Is it
after
possible?
UPT, you will do USG. This should be your answer. Okay. Then assessor again will ask you that UPT is also positive, and USG also shows that she is 6 weeks pregnant. So what will you do next? So next your answer should be, you will be asking her first that whether she wants to, you will be first give her news that you are pregnant, congratulations, and you will ask that do you wish to continue this baby. So if she say yes, then you need to ask her that do you want to register with us and continue the treatment, your ANC treatment with us, and also do you wish to deliver at our hospital. So if she say yes, or maybe you can convince her to, have it at your hospital, if she is staying nearby. If she's coming from some different city, then if she's traveling back, then you can't force her. But if she's from your city only, then you can convince her to register. And then after that, you need to take her history. Okay. So the first standard doesn't cover the history. It is included in third standard. But the thing is, whenever you are answering it, at the time of answering, assessor doesn't see that I'm only asking about first standard, so they should be ideally answering about first standard only. It doesn't happen like that. You can tell anything. So I would suggest whenever they go in this flow, so you will be also talking about third standard, that is history taking. Okay. So history taking talks about surgical history, medical history, and obstetric history. Okay, so first you will be telling about obstetric history. Next, you will be telling about surgical history, and last you will be telling about uh, uh, medical history. Okay. So before that, since I have said that I will go in sequence, so I will tell these three history in detail in that part only. But then you can tell in detail in start also, so that if you have covered this thing already, so what assessor will do at the time of third standard, he will not ask you anything and he will give you the mark there only. Okay. So you can be like that. It's not hard and fast, and it's not very it's not very as strict as you should go by standard only. It is not like that. So first we will talk about after history taking, there will be some investigation we will be doing. Some investigation. I have already given you the list of investigation. That is, first we will do, if she is coming for the first time, first you will do her blood group and RH typing. If she has already done it, then you need not to do it again, because blood group doesn't change, RH typing doesn't change for life. Okay. But if she's coming for the first time, then you should do this blood group, RH typing, and this doesn't repeat at all. Matlab, you should not repeat this test at any time. You should do it once only. Then after that, what will you do? You will do her hemoglobin first. Hemoglobin should be done at the first visit. Also, it should repeat in every visit of ENS. So every visit means what? You will say that patient is visiting 12 times in the 9 months to our hospital for NC checkup. So should we do for 12 times? If it is feasible, then you can do it. But if it is not feasible, then you should at least do one screening in one trimester. First screening would be at the time of confirmation, and remaining 3 are in 3 trimester. So ideal ANC visit, how many ideal visits should be there? This question will be asked by assessor. So what will you say? Can someone answer? What are the ideal visits in ANC? How many times should a lady visit to you? Minimum.
Minimum 4 visits.
Sorry?
Minimum 4 visits.
4, correct. So this should be the answer. This should be the answer, that minimum 4 times she should come. And maximum you can have as much as I mean.
Sir, is it possible to share PPT now? Present right now?
PPT. Actually, if we go by PPT, it is like it doesn't means I want to have it interactive.
Okay, sir.
So PPT, I will again share every PPT with you. You can have that. I mean, for reference, you can, I mean, have a look at it after my session
Okay.
if you wish to. I will share it in the group. So already I have shared it, but then I will
Sir, we
again
have
share it.
already, but present when we are listening now, it is better to see.
Yeah, it is
Okay.
there. It is there in PPT. I know that it is given in that demonstration form. Pictorial diagram is given there. So that you can see later on also. So I just want to have it like nothing is there and we are just interacting like assessor.
Okay, sir.
Yeah. So 4 ideal visit. First would be in first trimester. Second would be in second trimester. Third would be in third trimester, and after full term, that is 36 weeks to 40 weeks, one visit should be there. So these 4 visits should be there. And uh, so HB anemia, you should be screening at least for the 4 times, but you can screen HB as I mean as much as you can, whatever your protocol will be, but then minimum should be 4 times. Okay. The second test you will be doing is HIV, HBsAg, and VDRL. So HIV, HBsAg, and VDRL is the viral marker. So it is for viruses. Okay. Hepatitis B, HIV, and venereal disease. So basically, the gonorrhea, we say gonorrhea. So the 3 tests are done at the first contact. We perform these tests in first trimester ideally. But if patient visiting to you in second trimester, then you can perform it in second trimester as well. Um, Repeat these tests will be repeated after should be repeated after 6 months. That is window period. Window period is what that that a virus is already entered in the body, but it is not in the bloodstream. It takes time to to come in a bloodstream. That is called window period. We also call it as an incubation period of virus. So basically, you are infected, but it doesn't come positive. So because of these things in window period, we repeat the test after 6 months, so that if there is a window period for any lady, then it will be positive after 6 months. That's why we do it after 6 months. Also, there is a possibility to have blood contact or maybe, physical contact or maybe sexual intercourse and then transmission of the virus at that time uh, in that period of 6 months, so that whenever we repeat, we get to detect the positive patient. Okay. Then third thing you will be doing, important thing is sugar. Sugar, we we screen from 75-gram OGTT test. So can someone tell me what is the process of OGTT?
OGTT fasting sample we will take. Then we will give 75 grams of glucose.
Okay.
Then first 1 hour, second hour, third hour, 3 samples we will take.
Okay. No, you are telling it wrongly. So the thing is, first you need not to do any fasting sample. So basically, it is not necessary only to have it by nil by mouth. NBM is not necessary. So if she has taken anything like biscuit or something like that, or she had breakfast in morning and came to you, so it is okay. She can have it, and uh, this is kind of random blood sugar only. But the thing is, we are you know um here we are checking the tolerance of glucose. Whatever glucose she is consuming, uh, this is tolerance test. OGTT. Okay. So oral glucose tolerance test. Okay. So if she's taking 75 gram glucose orally, randomly, and what is the reading after 2 hours, that we check. So basically, when patient come to you, when lady come to you with like, she had breakfast and coming to you, it is fine. What will you do? You will tell her that this test will take 2 hours. So we will be giving you 75 gram glucose in 300 ml of water, that is 1 glass of water. And you will be you will have to sit for 2 hours, and then we will be taking your sample. So basically, at the time of giving her that water, the 75 gram glucose water, you just need to check that if she is not vomiting it out. I mean, sometimes it is like it becomes heavy, and then they vomit it out. So you just need to check that within if within 20 minutes of consuming, she's not vomiting it out. So basically, you have to just have watch on it for 20 minutes, and you ask her to have it slowly, not very fast. So after consuming that 75 gram glucose, you need to give her advice that she should not move much, because if she moves, if she is doing any physical activity at the time, so that glucose will be burned, calories will be burned, and then you will not get the positive, you will not detect the positive case also. So the reading will be below 140 mgdl, so that you can't detect um, the diabetes patient. I will tell you for what we are doing this. What is that? What that diabetes says, and why we are detecting this. So basically after 2 hours, you just need to take a blood sample of her and check glucose in glucometer, or maybe you can send it to the lab, and immediately you can have the result. So basically, these tests we are doing to detect the gestational diabetes mellitus. So there is a diabetes mellitus, that is chronic diabetes mellitus happens in general population, but there is a specific diabetes mellitus happens at the time of pregnancy only. That is called gestational diabetes mellitus. Okay. So gestational diabetes mellitus happens at the time of pregnancy only. Gestational is a term used for pregnancy only. So gestational diabetes mellitus, in short, it is called GDM. So how GDM is detected? GDM is detected if the patient reading is more than 140 mgdl after 2 hours. So that is after tolerance test. If it is more than 140 mgdl, then you can call that patient as a gestational diabetes mellitus patient. Okay, and then you will be sending that patient to your obstetrician. So your obstetrician will decide what medicine she should consume and what medicine she should be on, and the further screening he will do. I mean, he will suggest you, but then initially you will be doing this 75 gram OGTT test. Okay. And this question will be particularly asked by assessor. Tell me the procedure of 75 gram glucose test. Okay. And you, I mean, even if you ask like, tell me about how do you screen the sugar at the time of pregnancy. So in NC, so what kind of test you do? So you will be telling 75 gram uh, oral glucose tolerance test. Okay. So orally, you will be giving the glucose, and then checking her after 2 hours that what is the blood sugar level at the time of that after consuming the 75 gram glucose in a water. So this is 75 gram glucose. The next test you will be performing is urine routine with urine albumin also. So you can send it to the lab, or maybe you can have that strip urine uh, uh, urine proteinuria. For proteinuria, there is one kit comes like in that it has other indicators too, but for proteinuria it is very essential. You can dipstick from dipstick. So urine dipstick you can use, or maybe you can send it to lab and have the urine albumin SP. Okay. Uh, so these tests you will be doing in the first trimester, also repeat in the last trimester. Okay. Then the basic thing also you will be taking like blood pressure and temperature at every time. So this test will be like from the sphygmomanometer and the thermometer. So you will be checking it and you will be noting it down somewhere. Okay. Then the another test which is also important, they assessor might ask you that for endemic regions, what will you do for malaria? So if patient is coming from endemic region, then endemic like where malaria is prevalent. The cases of malaria is high in the specific area, but the lady doesn't have any symptom. So should we go for test of malaria for that lady, for that ANC? So answer would be yes, because if lady is coming from endemic area, then she might be positive for malaria. So you should be doing her test for malaria in every trimester. Okay. Then if she has that symptoms like fever with chills and other symptoms of malaria, then though you have to do it only whether she belongs to endemic area or not. Okay. Then at that time, you will also be performing Vidal test also for the typhoid detection. Okay. So that is all about investigations, and you are also making sure that at the time of ANC, you will be giving her tetanus vaccine, TTTD जो भी देते हो, whatever you are giving, you can give it in one in a 5th month of pregnancy, one in a 7th month of pregnancy. With that, you will be also giving her the nutritional supplement like calcium, vitamin D3, and iron, folic acid. Yeah, ma'am wants to, Gupte ma'am wants to, sorry, Josna ma'am wants to add something. तुम्ही म्यूट वर आहात मॅम, तुम्ही म्यूट वर आहात.
No, I want to go. I will close the laptop and be on the mobile. Is it okay?
Yeah, fine.
मग काय फोन लागलं तर फोन is available. Okay, I am.
Sure.
Okay, thank you so much. Continue.
Okay. So so I have told you the list of the investigation you should be doing in ANC, and also I have told you about what should we provide them, like what supplements and injections that you will be taking care in ANC. So it is not kind of the care you give in any disease condition, but it is the care you give for the facilitation of normal process in the body. Okay. So any doubt in this? Any doubt in any test? Or maybe if you want to repeat me anything, if you wish to.
No, sir, continue.
Okay. So we will go to the second standard, that talks about preparation. So preparation is what? Not your preparation. Your preparation should be there for the standard, but then here it talks about your OT and your labor room. So how much you are prepared for the normal delivery and also for the LSAs. So basically LSAs is mostly covered in the 16th standard, but here it only talks about labor room. But sometimes they may ask you for the OT as well. But here you should be focusing on labor room preparedness. So initial discussion only, I asked about your labor room preparation, your kits, your posters, your newborn corner, then your biomedical waste kit update. So I have already asked you this thing, but like at the time of assessment, it won't be like he or she will ask you directly that thing ki, tell me about your biomedical waste. I mean, have you prepared it, or uh, have you prepared kits or something like that? He will not ask that. He will be asking this thing in the standard where it is relevant. So I am talking about PPH box, he will see that box in PPH thing. So you should be sitting with the boxes, at least boxes which are movable. Don't sit with the sets which are sterile or which are already at autoclave. Don't sit with that because they will not see that. They will just ask you the question what all things are there in that set. But whatever is openable, which will not get infected if you open it, so that things you should be sitting with. And at that time SSR will I mean, if I'm asking about PPH, then he will be seeing that box, and for this standard he will be giving you mark on that basis. Like in infection control practices, I will be I will be also seeing your biomedical waste ke dabbe, and at that time I will give you that preparation mark. So preparation is not kind of question they will ask you. They will just observe it. You just need to be prepared on everything. Okay. So I hope you get this, because this won't have any question apart from one question. I will tell you what will be that question. So that question will be the newborn corner you have prepared. The major part of that newborn corner will be the warmer. So what they will ask you, one question will be one and only question will be asked in this standard will be, at what time you switch on the radiant warmer. Okay. So the ideal answer for this is 30 minutes before or half an hour before the delivery. So we will be like कि we how can we know that आधे घंटे में delivery होने वाली है? How will we know that it will happen in half an hour? So the thing is, it is according to our sixth sense. कि when should you open it, and it is not hard and fast that you should switch on it in before the cut 30 minutes only. You can on it before, you can on it also 20 minutes before also. But the thing is, logic behind this is it takes time to get warm. So that kind of that time is required to get it warm. That's why it is asking you to switch on it before 30 minutes of the time. Okay. So that should be the answer. That is 30 minutes or maybe half an hour. The third standard I have already told about the history taking. So third standard talks about history taking. Okay. So history taking is clubbed in this thing only, because if patient is coming to you for the first time, then obviously you'll be taking history first, and then you will send her for the investigation. So the thing is, at that time only, if you're telling this, it's fine, no issue. But if he is asking it separately, that what all history you will be taking, so you can tell it separately as well. So in history, it is not only about history taking, it is also about initial assessment of the pregnant lady. So what all things will be covered, I'll tell you in this. So first thing will be history taking, definitely. So history taking will be about obstetric history. Obstetric history, you already know the GPLA formula. Gravida, parity, and then live and abortion. GPLA you should be knowing. D and other things you leave it, but GPLA you should be knowing. So gravida, parity, are you clear what is gravida, what is parity? Are you clear on that, everyone?
Yes, sir.
Everyone knows how to use that formula, or maybe how to interpret it? Okay, then we will move ahead. Okay. So in obstetric history, you will be only asking about GPLA. Okay. So gravida, parity, and you will be writing that in maybe in formula, or if someone doesn't know the formula, then you can write it like that only. Gravida 1 or like that. So that is the thing. Second history you'll be asking her is about her surgical history. So surgical history, first significant surgery is for us is if she has previous LACS or not. If she has multi, if she's primary, then leave it, leave it about LACS. But then you will be asking about any other surgeries on abdomen. Okay, so on abdomen as well, and other surgeries also you'll be asking her. So basically, LACS is very essential for us because it is for us to take the decisions whether we want to go for normal delivery for that patient or LACS or whatever it is. So LACS is first, you will be asking her, then you'll be if she's primary or even if she has a normal delivery, first normal delivery, then you will be asking her that if she has any uh, other abdominal surgery, that will be again significant for us. And another thing you will be asking in surgical history would be any other history like open heart surgery, brain surgery, or maybe orthopedic surgery. So we will be aware what kind of health condition, health, surgery she has and what status she is, because if she has any patellar, like, knee surgery or something like that, orthopedic surgery also. So it will be helpful for you to giving her position, while giving her position also, you'll be knowing that she has that thing. So you'll be careful about it while conducting the delivery. So surgical history, third history you'll be asking is medical history. So medical history is nothing but the any non-communicable diseases if she has. So like hypertension is important, diabetes, thyroid, then asthma. So you will be asking these things to her. If she has it, then you will be noting it down. Also, I forgot to tell you about ANC also. In ANC, if you are doing investigation, the investigation should be written somewhere, maybe in her file or maybe in her NC card, where you should have access to it. Okay, so if a lady is taking file with her, then you are not having access to her reports. So you should have access to her not reports, but at least the values, whatever values is, like what was the status of HIV, what was the status of HbSAg in the first visit or first trimester. So like that, you should have some card with you for the lady with her unique hospital number on it and the name of the patient on it. We don't call them patient, actually it is client. They are not patient, they are not the disease person, so we call them client. um client's name should be there and her number or whatever you maintain for your hospital identity, for her hospital ID or something like that. You can give her and you can have that, because at the time of assessment, you will say that we are doing a number of investigations, but then you don't have any proof that, where are those things noted. So you should have that. You should have some NC card, or you should have some your record. Like you can have the register as well, and in that you have you note down everything for her, and then you can show it to the assessor that this is how we record it and this is how we maintain it. So after the surgical, so I'm coming back to this the topic I was covering. The third history will be asking its medical history. So if she has anything, then you will be also noting it down. And if there is any particular condition like hypertension or maybe diabetes, so you should be, highlighting that thing so that another sister, if she sees that file or some records, she will get to know that seeing that highlighted point, she will immediately get to know that she has some conditions. The lady has some conditions. Same goes with the investigations report. So wherever you are noting it down, you should be highlighting it where the value is less. Suppose the patient is anemic, then you should be highlighting that patient or maybe that value in front of patient. So like that, you will be get to know that what condition she is going through. So this is about the history taking, but in initial assessment in third standard itself, there is another points covered, which is like per abdominal examination. Also, how to calculate EDD from LMP and what are the sources of knowing EDD. Okay. So first you should be knowing that LMP, from LMP you should know that how to calculate the EDD. So from first day of last menstrual period, you will be adding 9 months plus 7 days in that date, and you will get the EDD. Okay, if you want to note it down, you can note it down, or it is there in your PPT. I will be sharing that as well. So that thing is there. You should be knowing how to calculate EDD from LMP. And also there are two more ways to have estimate of weeks is in. Okay. So estimate of week also the EDD. So now first the second source of EDD and very easy source of EDD is ultrasonography. So in ultrasonography, there is every sonography center gives you the EDD in the report. So EDD is given in the report, but sometimes the date differs. Like first trimester wala USG has different date, and second trimester wala has 8+ days in that. Also third trimester is different. So what will you consider? Which date you will consider? So the first one you will be considering. Okay, first USG, first trimester USG, or maybe first contact USG, you will be considering the EDD. Okay, that EDD is more relevant, and it is very much possible that it happens in those days only, plus minus 5 days, but then that date is considerable. Third, you will be also doing per abdominal examination for her. And per abdominal also you will get to know that where in which week she is. So basically, if it is at symphysis pubis, then it is 12 weeks. If it is still umbilicus, it is 24 weeks. If it is more than umbilicus, but then above umbilicus, but then you will be calculating it in centimeter or maybe fingers. So if 4 finger above umbilicus, then it is 4 weeks. So 1 centimeter is 1 week. Okay. So I consider this finger as 1 centimeter. You can measure it. Yours may be less or maybe more also. Mine is 1 centimeter. So 1 centimeter, 1 centimeter, 1 centimeter, 4 centimeter. So 4 centimeter is 4 weeks. So 24 plus 4 is 28 weeks. Accordingly, like we need to calculate it. And till 36 weeks, it goes to GP sternum. And after the head engagement, it comes down and it is below GP sternum. So 4 finger below GP sternum. So it is you can say see the photo of it in PPT. PPT has given the photo as well. So from this you can estimate the week of pregnancy, and also from that week you can calculate the EDD. Okay. So from LMP, from sonography, and from per abdominal examination also we will be estimating the weeks and EDD as well, expected date of delivery. Abhi, third thing is in initial assessment is per abdominal examination. In per abdominal examination, you will be seeing the grips. So grips, how many grips are there? 4 grips are there. So the first thing we have seen is the week estimation of the pregnancy, which we see from the first grip, that is called fundal grip. So fundal grip, how do you see it? So like from the zipisternum, you just start palpating, and wherever you see the resistance, you stop there and you calculate it. So if it is at umbilicus, then it is 24 weeks. If it is below umbilicus, then it might be 12 weeks or maybe 16 week below above pubic symphysis and below um this thing umbilicus. It might be 16 weeks, or till umbilicus it will be 24 weeks. So you can see that in that picture. I will share the PPT. I have already shared, but I will again share it. Then first fundal grip will be for this week estimation. Second pelvic grip will be for the fetal heart sounds. If she is more than 8 weeks, because after 8 week heart develops and heartbeat starts. So to see the FHR, you need to have this grip. So how will you see it? You will see it laterally. So we call it as lateral grip, and in these two grips are there sub grips, that is called left lateral grip and right lateral grip. So left lateral, it will be like you will palpate left side, and in right you will palpate right side. So if in right side you see the back of the fetus, then you will be keeping the fetoscope or maybe fetal Doppler probe there, and there you will hear the correct FHR. Okay, the perfect appropriate FHS you will be you can hear. So you'll be hearing so at the time of taking FHS, you should be palpating the back, and at there you will be keeping the fetal Doppler probe. Okay. So normal fetal heart sounds are for fetal heart rate is 120 to 160 beats per minute. Okay. If it is more than that or less than that, then you should be getting alert, and you should be you should be also informing this to your OBGYN. Okay, that FHS are less or maybe more than 160. So that is for FHS. And third pelvic grip, third and fourth pelvic grip, you will be seeing in after maybe after she is 34 or 35 weeks, she crossed the 34 or 35 weeks. So that is in later stage of pregnancy. That is called pelvic grip. So in pelvic grip, what will you see? First pelvic grip, you will be seeing that if position of the baby is correct. So we want vertex position. So you should be feeling the head of the baby at the pubic, near the pubic region. So how will you palpate it? You will be palpating, you can palpate it from one hand also, and you will see if hard surface, head-like surface is palpable to your hand. And the second pelvic grip is deep pelvic grip, which you will see after 36 weeks of pregnancy. So after 36 weeks, what will you see? The head of the fetus is engaged in the pubic bone or not. Okay. So how will you see it? You will be seeing it like this. You will go from upper, from the from abdomen like this, like this, like this, like this. And then if your hands touches, then the head is not engaged. If your hands goes like this, then your fetus head is engaged in this thing in pubic bone. So if head is engaged, then high chances of having the labor pain in 1 or 2 weeks immediately, or maybe within 2 to 3 days also. So it is the signal for us that she should be prepared for delivery anytime. So if it is in 36 week head is engaged, then it would by 37 or maybe mid 38 week the delivery will happen, labor pain will start. So head engagement you will see by this deep pelvic grip. So 4 grips: first fundal grip, second lateral grip, third pelvic grip, first pelvic grip, and second pelvic. So 4 grip. Okay. So grips are over. Now we will move to the another part that is called PV examination. Another part is fourth standard that is called per vaginal examination. Abhi per vaginal examination we don't do in NC. We only do when patient comes with the pain or maybe she's full term. Okay, 36 weeks cross. So any question in the initial assessment or maybe grips or some other topic? Any questions? Any queries? Am I telling? I mean, is the way I'm teaching, is it understandable to you?
Yes, sir.
Everything you understand, right? Whatever I say. Yeah, so that's fine then. Okay. So another topic is a clinical standard number 4, and that talks about uh, PV examination. So PV examination is very simple. First, I will tell you how will ask you the question. Okay. So assessor will ask you, tell me the difference between true labor pain and false labor pain. Can anyone tell me what is true and false labor pain? By the time I'll have some water. Can someone tell me?
The false labor pains is continuously it contracts.
Okay, good.
It will be relaxed and again contracted.
Correct, correct. Regular interval, it will come, true labor pain. What will be the other thing? Acha, tell me that if some lady has some constant pain in only one part of abdomen, okay, maybe the lower part of abdomen, and the pain is constant. Is it labor pain?
No, sir.
Okay. Okay, so it is, you will call this as a false labor pain. Okay. So one labor pain is radiating from back to the front. Is it true labor pain?
Yes.
Okay, very good. One patient has the pain and you ask her to lie down and she's feeling better. Is it labor pain?
No.
Correct. So these are the difference. So you need to, the labor pains, true labor pains are not at a constant place. It radiates from one place to another place, uh, and it comes at regular interval. Uh, it stops and then again come. But the constant pain is a false labor pain. It might because of acidity, because of appendicitis, because of uh, GI tract infection, or maybe Braxton Hicks also, the false contraction also. Okay. So that is called false labor pain, and true labor pain are radiate from one place to another place. Then it never relieve by, I mean, when you rest or when you take medicine, it doesn't stop. So it is there only. So that is true labor. Okay. So after this question, how will assessor take you through the PV examination? He will ask you, one patient is there with true labor pain and 37th week she is coming to your hospital with true labor pain. So what will you do for her? She is registered with you. She has her file. You have everything of her, like every report of her with you. And now she is with labor pain, true labor pain with 37 week of pregnancy. What will you do?
First, we will assess with PV.
Correct. So now the moment you say PV examination, he will ask you, tell me the procedure of PV examination. So can you tell how do you do it?
Can you repeat the question, sir?
Yeah, so I am asking you that I'll tell you that when you say, the moment you say that you will do PV examination for this kind of patient, so assessor will ask you, tell me the procedure of PV examination. What steps do you follow? So I am asking you right now that please tell me what steps you follow in PV examination.
Okay. First, we will check whether it is true or false pains. If it is really true pains, we will go with the PV examination. We will clean with antiseptic solution. Where sterile glove, using with antiseptic solution, we will clean and we will check for any PV leak and what to say, os opening of os in how many centimeters and any show is present or not.
Okay.
Everything we will check and whether it is engaged or not,
Okay.
we will check this.
Okay. You have told like how you do it, but many of the things are correct, but many of the things are missing also. I mean, maybe you have missed it by while telling only, but you must be doing it. So I'll tell you how you should ideally answer. You should be ideally answering to these questions. So first thing will be you will be cleaning your hand. So hand wash is important. So hand wash you will be doing by 6 steps. You know the 6 steps.
Yes.
So the Suman K formula already I have told you. S is Sida, U is Ulta, M is Mutti, A is Angutha and finger, and then N is nails, and K is Kalai. Okay. So by this you will tell this in detail. Okay. Suman K, you don't assume that he knows it. He knows it everything because he's proxy assessor as well as NABH assessor. Okay. So he knows it, but then he is expecting from you that you should tell it in details. Okay. So you are telling hand washing, then you will be telling about the gloving as well. So gloving, what will you do? You will first air dry the hand, and then you will do gloving by gloving technique taught by Josna ma'am. So like first glove, you will be touching it from inside, and second glove from outside. So you can see those videos again, which is there on YouTube already. So how to wear a glove properly. Then third thing you will be doing is you will be maintaining her privacy first. You'll be giving her position. Before giving position, you will make sure that her bladder is empty. These detail you have to tell them, because if you see the proxy question paper, even if you can go to the self-assessment, you must have seen the detail point and you have click on it like yes, no, whatever it is. So assessment happen like that only. You will be telling the minute detail. I'm sure you must be doing this. But while telling, hospital doesn't tell this, and then sometimes it goes negative and they cut the mark there
Okay.
because they don't ask it again, because they also don't have time. So sometimes they ask it, cross question it, but then sometimes if they doesn't ask, then it will be problematic for you because you have not told them. So then also you will be telling that at the time of hand washing, you will be removing the ornaments. I missed that point. So you'll be removing ornaments. Then you ask the lady to empty the bladder. You are maintaining her privacy like curtains, also the whole tile to cover up her private parts. After that, what will you do? You will be doing the cleaning part. Cleaning part you have already told, but then you haven't told about the rotation you're following and how many swabs you are using. So like in the demonstration, Josna ma'am has already shown you that, one swab with antiseptic solution, one side, then another swab, another side, and a third swab,
From
the
top.
middle side. Okay. You are cleaning it, and at the time of procedure, you will be taking verbal consent of the patient that we are going to do your PV examination and this thing will happen in that. In the local language, you will tell her that we are going to do this, and by this we will get to know this, and this is very necessary procedure. So we are just informing you or maybe taking your consent to do. She will not deny, but then if you tell her, then she will be more comfortable. Okay. Ask her, don't get afraid or don't get panicked. do be comfortable. We will be doing this with, maybe you will have thoda sa pain, but then bear it because it will not be too much and it is very necessary procedure like that. You can convince her for the PV examination, and after that you will be performing PV examination. What will you do? You have already wore the glove. You will take thoda sa xylocaine jelly and on your dominant finger first, dominant hand finger first. First finger you will be taking and then you will be inserting one finger only. After inserting it, you will see the dilatation there. Dilatation is more, then you can insert another finger. Don't do like, you are removing, again inserting, removing, inserting. Insert it in a go. And then if you feel that two fingers are necessary, so then remove it and insert two finger immediately. Okay. Then you will have to check for dilatation first, then effacement, then also membrane. If membrane is there, some balloon kind of thing, if you can feel, or if membrane is not there, leaking is there, like you said, you can see the presenting part of the baby. You may feel the head, or you may feel the buttocks, or you may feel the back as well. So that is transverse line. So you from that you will also get to know that what is the position of the baby. And if the patient is primary, if the lady is primary, client is primary, then you will also see the pelvic adequacy. After removing it from the cervix, you can see the bony premises, and if it is, make sure that it is more than 10 centimeter. It should be more than 10 centimeter. 10 centimeter. If it is not there, then it is called CPD, cephalopelvic inadequacy. Okay. So, if pelvic is inadequate, then anyhow you will be taking her to cesarean section, because bacha will not come out of that space. So, and this happens in primary only because if she is already has inadequate pelvis, then she must have done the previous LSS also. So you will be taking her for LSS only. But if she is primary and if it is an inadequate, then you will be taking her to LSS. Okay. So those are the things, and these things you will be noting down somewhere. Okay. PV notes. PV notes is must, and if you ask to show the PV notes, you will be showing it to the assessor. Okay. One more thing, you can see that after removing your fingers, you can see the color of the liquor. If it is yellow or reddish, then it is problematic. If it is clear, then it is not problematic. It is normal. Okay. So I hope you got this thing. One more thing in PV examination is you are suggested to perform PV examination in every 4 hours. Okay. It is not necessary to do frequent PV examination to avoid the infection. Okay. I don't know if you're practicing this or not, but then it is mandatory or maybe necessary. But then since I have said that, there are some conditions where you can do early PV as well. Okay, if you see that some blood is coming, or maybe you already seen that baby is not in a good position, or maybe some other condition happens, and then you need to check it. So you can check it definitely. Don't wait for 4 hours, but in normal cases, it is recommended to have it after 4 hours only. Okay, to avoid the chances of infection again. If you're doing it again and again, then infection chances are there. So that's why it is recommended to have it in 4 hours. Okay. So now coming to the point that is discussed in first part only, partograph. So the fifth point is fifth clinical standard talks about partograph. Okay. So till here, anyone wants to ask the questions, queries, or anything? Everyone is noting down. So now I am expecting some
Sir,
questions.
I have a doubt. In GTT, we don't need to take fasting sample, right?
No. You don't need to.
After giving 75 grams of glucose, after 2 hours, only one sample we should take.
One sample you should. Yes.
That's it.
Yes. And
No need to
you
take
don't
any-
need to call patient NBM, Kneel by mouth.
Okay.
I mean, you can perform the test whether she has taken anything, or she had breakfast, or whatever she had.
Or anytime.
But then you make sure that after giving glucose 75, she should not eat anything for 2 hours,
Okay.
or she should not perform any physical activity.
Okay.
Yeah. So that is there.
Okay, sir.
Okay, so we'll go ahead. So partograph is like, we are plotting something which shows the progress of labor in a one place, in a one paper. So the partograph, you are already aware how to plot it. I have already asked ma'am. So I will now I would like to ask you questions on partograph, and then we can have some discussion around it. So tell me, I am just telling you one case scenario. One lady came with the labor pain, and I did her PV, and I found her 6 centimeter dilated. Okay, 6 finger dilated, 6 centimeter. Okay, and the time is morning time. She is a primary, and now I have to plot the partograph. From where I'll start it? Where should I start it?
From the starting, because she is already 6 centimeters, from starting we have to start.
From the start. So
From first PV only we should start pathogram because
yeah,
she is already 6 centimeters.
yes, correct. So she is in active phase of first stage of labor. Active phase. Okay, latent phase and active phase is there. So active phase starts after 4 centimeter, and we also start partograph from 4 centimeter. So on 6 centimeter, we will be starting partograph. So on which line we will be starting it?
Which is line? Alert line, sir.
Alert line, correct. Correct. So where does it comes for 6 centimeters? Can you tell me where does it comes? Is it comes at the start, or maybe in somewhere in middle?
Yes, sir.
Where does it comes?
Timing, sir. What time you told?
Time you consider 9 a.m. in the morning.
9 a.m. Okay.
Okay, so everyone is with partograph, blank partograph.
Yeah. I arranged the pathogram.
Okay. So the thing is, I'll just tell you the case study then, and then you can plot it and you can show it to me.
Okay, sir.
Okay. So these cases only I'll continue. So 6 centimeters she was, and at 9 a.m. Her name was Asha. She was 28-year-old, and she was primary.
Okay, ma'am.
Okay. Her membrane ruptured at 6 a.m. in the morning. And she came to you at 8 p.m., 8 a.m. in the morning, and it's at 8:30 in the morning, and 9 a.m. you done her PV for her, and then she is 6 centimeter dilated. At the 9 a.m., the contraction was of 19 second. 3 contraction were there and was of 19 second. The one contraction lasted for 19 seconds. Like 3 contraction came in 10 minutes at 9.
Amniotic fluid, sir.
Sorry?
Amniotic fluid is clear. Liquor is clear.
Amniotic fluid is clear, yes, at the time of PV. And FHS were around 130. Okay, done. BP blood pressure 120 by 30, 120 by 80, and pulse around 75 pulse per minute, beats per minute. Okay, so now coming to the everyone done with 9 a.m. Reading?
Yes, sir.
Okay, so on 9:30, what will I see? Will I do PV again?
No.
Okay, so 9 a.m. पे PV किया है, तो when will I repeat it? What is the ideal thing?
After 4 hours.
After 4 hours, right? So 10 a.m. I will do it. Sorry, not 10 a.m. 1 p.m. So now 9:30 reading is amniotic fluid is clear. From leaking, I am seeing it. And contraction were 3 contraction lasting for 22 seconds. FHS were 140, 9:30. Then coming to the 10 a.m. reading, 10 a.m. it was contraction was 3 contraction with intensity of 25 minutes, 25 seconds. One contraction lasts for 25 seconds. Then amniotic fluid was clear. Amniotic fluid was clear and FHS were around 130. Then I'm coming to the 10:30 reading. 10:30 contraction were 3 contraction again for 27 seconds. It was lasting. Then
Sir, can you go little slower because someone is not.
okay, no issue. So should I do one thing? I will just share the screen, share my screen, and I'll type it there.
Okay.
Okay, so you can refer that, and once you're done with your paragraph, just let me know.
Okay.
I want to share the whiteboard. No? I will just see how the whiteboard is. Is my whiteboard is visible to everyone?
Yes, sir. Yes, sir.
Okay, so I'll just type it here. Okay. So So till 10 a.m. you have done it, right? So from 10 a.m. I'll type it.
Okay, sir. Some text messages there on top of that your typing message, sir.
Is it not visible?
No. Some text message already what message is there that is showing on in front. Organize and facilitate
So
the.
should I type in text?
You type it and send, sir. This is what.
Is it not visible?
Is it visible on top of the art?
So I can increase the font size as well. Let's come back to the. Now it is more clear. But the thing is, it will like you won't be able to see that the.
No, just I sent a screenshot pic, sir. Can you check once with your WhatsApp?
Yeah. I'll stop this and I'll close whiteboard. I'll just type it in a chat box. Okay.
Okay, sir.
You will be able to see, na, in chat
Yes.
box.
Manju, chat box open చేయడం వస్తుంది ఇంకా. Yes, sir, we can see. Name, say corrections from that 25. Dot com.
Let me know once you are done with it.
Sir, you can continue with the other topics, sir. I will make them to practice photograph.
Okay, so what is your experience right now? Is it like, are they able to do it, or like some?
Yeah, they are able to do it, but what to say, these contractions, dot and curve lines and dark lines, they are confused.
Okay,
That I
okay.
will explain them, sir.
No problem. So you take one session on part
Yes,
for them.
yes, sir.
Okay, no issue. Okay, so we in Partograph, you just make sure now you know how to plot it. You just have confusion in that thing, and madam will also again, you know, revise you on the thing. One thing is will be asked by assessor is, from Partograph, how will you get to know the obstructed labor or prolonged labor? Okay, so obstructed labor is that if dilatation is missing, is called obstructed labor. If your line, your dilatation line is coming below alert line, or maybe reaching action line, then it is obstructed labor. If the both the things like contraction is also missing and dilatation is also not, progressing, then it is called prolonged labor. Keep this thing in mind that if it is asked that what is prolonged labor and what is obstructed labor and how will you identify it from the photograph, then you will be answering this, okay? Or you should be knowing this. Also, one more thing, that if your dilatation comes to the action line, then you will be taking action. Matlab, you will have to inform your obstetrician that this patient needs to, take to the OT for the operation for the LSS, because action is needed if it is reaches action line. If it is not progressing and reaches action line. If it is between action and alert, you can try augmentation, you can try uterotonic, you can try anything. Okay, but if it is reaching action line, then you need to take the action. Keep this in mind. So now we will go to another topic that is called respectful and supportive care. So respectful and supportive care is again a topic which will be like, which won't have much questions. Okay. So questions will be like, it will be observed from another topics like uh, respectful and supportive care is what is,
Sir,
yeah,
can we take for 5 minutes break and come back, please?
yeah, sure.
Okay.
Yeah,
By 3:45 again we will start.
sure. Let me know once you are back.
Okay, thank you, sir. Sir, we are ready, sir. Manjit, sir.
Yes, I am also here. Okay. एक minute, बस. Okay, so the next topic talks about, that is sixth topic, sixth clinical standard is about respectful and supportive care. So it is like again a standard which will not have any direct questions, but it may have direct question as well. So the thing is, respectful and supportive care is all about, you know, um, giving lady that autonomy or respect, or maybe you know, the friendly environment, the homely environment. So there are many things to ensure in this. So like I said, in PV examination, there is we ensure the privacy. This is also a part of this thing, respectful and supportive care. Okay. So if you are maintaining privacy and if you're telling that in PV examination, so assessor won't ask you that question, that if you maintain a privacy or not, because you already covered it. So likewise, other things also covered in other things. So other topics. So basically, uh, it talks about first important thing in the respectful and supportive care is, while conducting the delivery, if she wants someone with her, then you should be allowing that person in the labor room. That is the first subtopic of this thing. So the thing is, when you allow it, she will feel more comfortable. She will feel more homely, because you are not known to her, but that person is known to her. So she will feel homely, and then she also feels respectful. So basically, she feels comfortable. So when she feels homely, comfortable, the natural oxytocin releases automatically, which we call the happy hormone. So oxytocin naturally in the body releases, and you know what is importance of oxytocin during the labor. So because of this thing also, we are uh, promoting the respectful and supportive care where patient get the homely environment. The second thing in this standard is you should be maintaining privacy and confidentiality of the patient. Privacy, I have already told you that you should be, wrapping, hiding her private part, or maybe, um, uh, using a curtain. Then door should not be open. If you have 2 to 3 tables in the labor room, each labor table should having one curtain in between. If there are 2 3 deliveries happening at simultaneously at a time, so you should make sure the private about the privacy. Second part in this is confidentiality. Confidentiality is whatever information she has, whether it is normal or abnormal, you should not be telling it to others. That is confidentiality. You must be knowing the word by confidentiality. So confidentiality should be maintained. Then third thing you will be doing, that there should be not any bias treatment to anyone. Like if someone is poor or someone is rich, then on that basis you should not be giving the treatment. You should equally treat everyone. Then fourth thing in this is verbal consent or written consent. Consent, I have already told this in PB examination. So yeah, if you are doing this, already you have told this, so he will give you mark there. He will not ask you if you are taking verbal consent or written consent. Um, these are the points you should make sure that you are following, so that she will be have that homely feeling. Also, while talking to the patient, last and most important point, while talking to the patient, you should be, very respectful. You should not be, screaming at them. You should not be verbally abusing them. You should not be physically abusing them. So that is those are the 5 things you should be making sure, and then your one standard will be covered in this. Okay. Whatever procedure you are doing, if you are managing complication also, or if you are doing normal procedure also, you will be doing this, or you will be following all these 5 things whenever you are conducting anything at your hospital. When patient get admitted to your hospital, keep in the mind that you should not be doing all these things, and you should be treating her cordially, also allowing birth companion, privacy, confidentiality, and then consent, and then not any physical or verbal abuse. Okay, and biasness should be allowed, should be avoided. So after this topic, it comes to normal delivery, which is very important topic of uh, POCSI Manyata standards. So Manyata standard number 7 is normal delivery. Normal delivery is also called as safe and clean birth. So in normal delivery, you should be taking care of 6 cleans. 6 cleans are clean hands. Like I said, that hand washing is important. Clean hands, clean surface, clean perineum, clean cut, clean towel, and clean clean surface. One clean I am missing, but you just see it. Okay, सारे cleans मुझे भी ध्यान में नहीं रहते. I don't remember it. So 6 cleans are there. 6 cleans. Clean.
Clean
Okay,
clamp.
so clean cut also. Clean cut. So you should have the sterile Caesar also with. So 6 cleans you should be taking care. In this thing, you will be how question will be asked. So assessor will ask you that uh, uh, you are plotting a partograph, and you are seeing that 10 centimeter is already dilated. Now you are seeing that the head of the baby is visible. What will you do now? Okay, this kind of question will come. So what will you do? You will say that we will start preparation for the normal delivery. Abhi, what is the preparation? Here again there should be the thing that bladder of the mother is empty. So you make sure that bladder is empty, and then you will start other things, like you will give her lithotomy position. Then you will clean your hand. You will wear the gloves according to the gloving technique. Again, you will clean the things like perineum cleaning, like you clean it um, in the PV examination. Here, you will also say the privacy will be maintained. Whole towel will be used. Also, the birth companion. If she wants someone with her, you will be allowing him or her. Then the warmer, half an hour before you will on the warmer, switch on the warmer. So you will tell all these things in detail, and then while conducting the delivery, you will again tell her that your delivery is going to happen. Please don't get scared. You just be comfortable. You just take deep breath, and whenever contraction come, just push. Don't push when contraction is not there, or don't give the fundal pressure. Fundal pressure is not allowed. The WHO doesn't recommend the fundal pressure. Okay. So at the time of delivery, what will you do? It says that every case is not required to give episiotomy. So to avoid episiotomy, you should be giving the perineal support. So perineal support, how will you give? With a pad, you will just hold the lower part of vagina with your non-dominant hand, and you will be conducting the delivery, or maybe the facilitation of the head delivery with your another hand. Or maybe if 2 people are there, then one will be holding the perineal support and second will be facilitating the head delivery. Abhi, how will she facilitate the head delivery? So whenever head is coming out, you just have to tap like this, or wherever. I mean, it can come from backside also, so you can tap like this. So the flexion of head is maintained. You need not need to hold the head and pull it. You just tap it like that, and then it will happen. Okay. The delivery of head will happen automatically by maintaining the flexion of head. And once the head is delivered, you can leave the perineal support, because at the time of head delivery only, the chances of tear is possible. Otherwise, it is not. Other part of body gets delivered by that space only. Okay. So the thing is, at this time, what will you do when head is delivered? You will just wait for 2 to 3 seconds that head moves to the some to maybe at right side or maybe at left side. So head moves a little, and then when head moves, what will you do? You will just hold the upper shoulder, whatever, whichever the upper shoulder is. If he's turning at left, then this will be the upper shoulder, and if he's turning at right, then this will be the upper shoulder. That is called anterior shoulder. So anterior, you will leave everything and uh, uh, grab the upper shoulder, anterior shoulder, and pull it down. First, pull it down. So once till this body is delivered till till the abdomen, then you will leave the upper shoulder, abdomen, anterior shoulder, and you will grab the posterior shoulder, which is lower shoulder, and then pull it up. Okay. So once you pull it up, the baby will get delivered, legs and everything will be out. Okay. So that will be out. Then at that time, what will you do? You just put the baby on mother's abdomen. Okay. So before putting the mother on the mother's abdomen, if baby is too, I mean, with I mean, it is if it is too dirty, I mean not dirty, but then fluid is like that is so much on his body. If you can take one towel, one pre-warm towel, which is in the warmer, that can with that you can clean him and then put it on the mother's abdomen immediately and wrap him with another pre-warm towel. Okay. So till here, the normal delivery procedure is done. Okay. Any doubt in this? Delivery is done. Anyone wants to ask something?
No, sir, yet here.
Okay. So from here, eighth standard will start, and that is called essential newborn care. It is linked. It is interlinked. Three topics are interlinked. That is normal delivery, ENBC, and AMTSL. Essential newborn care and active management of third stage of labor. Those three topics are linked, but then it is separate standard. So you may tell it in the flow that so that three standard will be covered together. Okay. So second standard in this, which is eighth standard, it's called essential newborn care, is start from where you deliver a baby on mother's abdomen. So once you deliver the baby on mother's abdomen, what you need to do? You will have to do the delayed cord clamping. Delayed cord clamping is what? You need to just allow the blood to pass from placenta to the baby. So you need to wait for the blood to pass so that it takes 1 to 3 minutes after the delivery. So you don't have to clamp the cord immediately, because if you clamp immediately, then that blood will stop in between. So you can do one thing, you can check the cord pulsation. If cord pulsation is stopped, then you can clamp it and cut it. But if it is not stopped, then wait for it and then clamp it. Okay. So that is called delayed cord clamping. You will tell this thing to assessor that we are performing delayed cord clamping, and you will also start this delayed cord clamping from today. So after delayed cord clamping, you will not after during this period, like you are waiting for 1 to 3 minutes. So 1 to 3 minutes you are waiting. So in that meantime, what will you do? You will do the head-to-toe examination of the baby, whether there is any congenital anomalies, whether their cleft palate or maybe spina bifida, or maybe sometimes anal opening is not proper, or maybe one finger is missing, whatever is there. So you will just observe that and you will write it down if it is there. If it is all normal, Then also in the baby notes, you will write that ki every part of the external part of the baby is normal. Maybe internally kuch ho sakta hai. Internal defaults may be there, faults may be there, internal anomaly, but externally you have examined and it is everything is perfect. Okay. So then what will you do? Once you have done this thing, you just put baby for some time on the mother's abdomen only. And one of the hospital, maybe you only told me that you do the practice of, breastfeeding on that, crawling and everything is allowed. And then breastfeeding you start then and there only. So if you're doing that, that's fine. If you're not comfortable with to do that, you can take the baby to the warmer first and do other things like vitamin K administration and weighing of baby. So you will weight the baby. You will check the weight of the baby. What is there? I mean, if it is normal, more than 1800 kg, then the baby is normal. It is not called LBW, low birth weight. If it is 18 below 800 gram, then it is called LBW. So if LBW baby is there, you will be giving half half 0.5 ml vitamin K injection with insulin syringe subcutaneously. If baby is normal weight of normal weight, then you will be giving full vitamin K ample to the baby subcutaneously with insulin syringe. Okay. After this procedure, what will you do? You will wait for some time. You will keep baby in the warmer for 5 to 10 minutes, and immediately after this all this procedure, if baby is normal, then you will start the breastfeed. Okay, you will initiate the breastfeeding. At that time, you will also teach, if she is primary, you will teach her how to breastfeed. What are the technique of breastfeeding, proper breastfeeding. Okay, proper attachment and everything that you know already. Okay, so that is the things you do in okay, that is the thing you do in essential newborn care. So essential newborn care is over. Then what will you do in normal procedure? If everything is normal, you will be conducting the placenta delivery. So placenta is third stage of labor. Now I will tell you the stages of labor. Stages of labor, please note it down somewhere. First stage of labor is from the true labor pain to 10 centimeter dilatation. First stage of labor. In first stage, there are two phases. There are two phases that is called active phase and latent phase. Latent phase is longer, but active phase is faster. So from 4 centimeter onwards, it is active phase, and true labor pain to 4 centimeter dilation, it is latent phase. Then second stage of labor is baby delivery, from the full dilatation to baby delivery. And third stage of labor is placenta delivery. That is from the from the delivery of the baby to the delivery of the placenta. Okay. And from the delivery of the placenta to further 2 hours, it is fourth stage of labor. Okay. So keep this in mind. Abhi, we are managing third stage of labor. So this is called active management of third stage of labor. So why it is active? Why it is called active management? Because we have to actively manage it. It is the normal procedure again, but you just have to facilitate the process. Sometimes what happens is we don't give attention to the placenta delivery, or sometimes we just deliver it like this. Baby is already delivered. What is with placenta? We will deliver it like this. But because of that, PPH happens. Or maybe we don't give attention to the placenta, or maybe this stage, and then PPH happens. And the PPH deaths are more than 37% globally and in India. So because of PPH, if you want to avoid happening occurrence of PPH only, then you will be performing this very actively. That's why it is called active management of third stage of labor. But it is a very simple procedure. It is not hard and fast. It is like only they have told the 4 step of it. 4 step is what? One is you will be giving uterotonic immediately after the delivery of the baby, and in between the delivery of the placenta. Within the 1 minute, you will be giving 10 international unit IM. That is the first step. Second step, but before first step, you should be checking the second baby in the uterus. If it is twin or triplet, then you should not give oxytocin immediately. You should wait for delivery of the second or third baby, and then you should be giving the oxytocin. So this is given for contraction of the uterus, so that if baby is already there, second baby, then that baby will die inside because contraction will start. Okay, strong contraction will start after uterectomy. So you should wait for second delivery. Twin is there. If it is not there, then you should give oxytocin. Second is you have to perform CCT, that is called control cord traction. So traction is jhatka we give to the cord, and in control. In control means what? Whenever contraction comes, you have to pull the placenta, pull the cord of the placenta. Okay, that is the only logic of control cord traction. And whenever you see some blood or some length, means the placenta cord of the placenta coming below, then that is the placental signs of separation. So if you see that some blood is coming and placenta is getting separated and you can see it at the opening of vagina, then you should leave another hand and you should be holding the placenta with two hands, and in rotate motion, you should be delivering it. Okay, you should be taking it out. That is called control contraction. Third step here, they are suggesting is the massage of the uterus from the abdomen. Massage of uterus. Uterine massage you should be continuously doing for the contraction. And another step, which is sub step, again, fourth step, is examination of placenta. In placenta, you will be examining the maternal side and the fetal side. So maternal side, you will be seeing if any fresh blood is there, so that you will get to know that if some pieces of placenta has been stayed back in the uterus, and if it is stayed back, then there is high chances to have the PPH, postpartum hemorrhage. So you will be alert in this case, or maybe you can remove that piece manually by giving uterotonic, extra uterotonic, or maybe manually removing it. But manually removing requires the expert. So OBGYN should be there at the time of manually removing. Whether the retained placenta is there, retained placenta also manually removed, but in the expert observation. Okay, expert supervision. So that thing is there. Then at fetal side, what will you see? You will see that amnions, chorions, and also the veins where it is distributed is properly distributed. Also, the center of the cord is in the center, and when you hold placenta like this, it should come down like umbrella. So it is normal placenta. If it is not normal, then if placenta is unhealthy, then there might be some problem with fetal development. So there might be some congenital problems to the fetus. So that you should note down everything of the placenta before throwing it out in a yellow bag. You should be knowing everything about placenta. Okay, so you will not get chance to see placenta again. That's why I'm telling you that you should examine the placenta. Okay, so that is all about AMTSL. Okay, so we have reached to the ninth standard, and further to this, there will be the complication management session, complication management topics, and also infection prevention and postpartum care plus options classification. So what do you suggest? Should we continue it today only, or should we take another session because it will be so much of bombardation?
Tomorrow shall we continue with the
Tomorrow, maybe, yeah, tomorrow we can continue at the same time, 2 p.m.
Okay.
I will ask Josna ma'am to again create a link, or maybe we can create on this, we can join on the same link.
Okay, sir.
So yeah, because I also don't want to get you to get saturated. That's why I wish it to have tomorrow.
Okay, sir. No problem.
No problem?
No problem, sir. Tomorrow. Anyway, I dropped for 2 days.
Oh, no problem, no problem. Because I am also feeling right now that, it should be in the 2 days, because I am telling you exclusively in English, no? So I'm
Yes.
telling each and everything. For other hospital, like they have already listened it in Marathi or maybe Hindi. So it won't be problem for them if I take in one day also, one session also. But for you, it is required to have 2 days.
We'll have it tomorrow remaining sessions, and we want to have a one mock.
Yeah, mock we will be taking. Mock I won't take. One madam will take.
Okay.
She will be taking your mock and she will be giving the feedback, because I am only taking training and I am only doing mock will be like biased thing. So she will be taking it and she will be giving feedback to me. And if required, I will take one another session, quick session for half an hour or 1 hour maybe.
Possible tomorrow with like the small PV examinations and the fundal height and all for at least 10-15 minutes with Jyotsna madam.
Sure, sure. I'll ask Josna ma'am and she may demonstrate from there also.
Okay, sir.
Sure, sure, sure.
Thank you so much, sir.
Thank you, thank you, thank you.
Thank you so much. We are happy today that you are understanding.
Yeah, I hope you get my English, because my English is not the southern English. I am like I'm a
We are understanding.
yeah, it is. Yeah, that's
Okay.
why I was
Possible, please send this record to us, sir.
yeah. Thank you.
Thank you so much, sir.
Yeah, thank you, thank you. So I'll end it here and I'll send you the recording of today's session.
Okay. By tomorrow again by 2 p.m. we will gather again, sir.
Sure, sure, sure.
Okay. Thank you, sir.
Yeah, thank you, thank you.